Welcome to the next Aspen webinar, Falling into Excellence. We are going to focus on advances in interventional spine and nerve care with highlights in top research. And this is going to be hosted by our moderators, Dr. Timothy Deere, Dr. David Syed, and Dr. Jason Pope. Gentlemen, take it away.
Well, thanks, Michelle, and welcome everyone. We had a lot of these events over the past year, and today we thought we'd have a 1-hour program. It'll be very, really compacted into really the most important information. We want to just really fall into excellence as we have the fall equinox moon tonight around the United States, and I know we have some international folks joining us as well. And tomorrow, autumn starts in America, so this is a good time to reflect on what's coming forward in the next year. And we want to go backwards now and look at some of the research that's been presented. And you see our agenda here. We're going to be talking about percutaneous injection of the disc. We're going to be talking about salvaging poor outcomes by using things like minimally invasive treatments. We're going to be talking about prospective multi-center studies looking at axial back pain and PNS. And we're going to be talking about minimally invasive lumbar decompression. So that's what we're going to present. We'll also be recording these. You'll be able to go back and look at them later on the webinar. I'm going to give it to David now to talk about our sponsors and introduce the rest of the evening. David.
I'm going to let Jason say a couple of words first, our new president of the American Society of Pain and Neuroscience.
Thanks, David and Tim. And I'm so excited about the space that we're in. I mean, I remember a number of years ago when I was in fellowship, we didn't really have access to a lot of these technologies that we're talking about tonight. And it's so hard to really do these therapies justice when we have such a robust annual meeting schedule. And so I think this is a really great opportunity to take a deeper dive into some of these therapies. I appreciate all the attendance and the interest in spending some of your time tonight with us. So with that, I'll hand it over to our Vice Chairman, Dr. David Syed, to introduce our first speaker.
Yeah, thanks, Jason and Tim. So I think this is really exciting. I think, as we focus on, our major initiatives of American Society of Pain and Neuroscience going forward, I think as we see that the field is advancing so fast, I think Aspen has, we want to be really kind of the pulpit for all the new and breaking data in this field. And I think events like this and our event in January are really going to be where people need to come to see the latest and greatest data in our field, because we all know there's a lot of new innovation, but it really needs to be validated and it needs to be looked at critically. So I think Aspen is really the source that we all need to come for that. So starting off most appropriately is our Vice President of Scientific Affairs, Dr. Kazra Amar-Delfin, who really had a very interesting study that he led at our annual meeting. And this is, in the realm of intradiscal therapies and regenerative medicine. He's going to talk about hydrofil, percutaneous injection for lumbar disc augmentation. Kaz, the floor is yours.
Thank you so much for that, Dr. Syed, Dr. Deere, Dr. Pope. Thank you for the opportunity to be able to speak to all of our colleagues. Good evening, everyone. I'd like to first congratulate Dr. Pope for becoming our new president at Aspen. You have very big shoes to fill, and I couldn't think of anybody more capable who could follow the legacy that Dr. Deere and Dr. Syed have created. Nowadays, a lot of research is being done in filling a very big treatment gap that we have, and that's disc degeneration. There's been a lot of things that have been done in the past. There are things that are coming in the future, but now is the time for the modernization of the things that we can potentially use to fill the treatment gap. One of these things is a product called hydrofil, which is a percutaneous injection for lumbar disc augmentation. Next slide, please. These are my disclosures. As David mentioned, I'm the Vice President of Clinical Affairs for American Society of Pain and Neuroscience. I'm the former Vice President of Pacific Spine and Pain Society. I'm also the Director of Clinical Research at IPM Medical Group in Northern California. I've had the pleasure of being involved in a lot of groundbreaking research. Although this research for Regeltech and hydrofil has not been done in the United States yet, I'm super excited about presenting the early data for this. But before I get started, I'd like to point out to everyone that this is indeed an investigational product. It is not being used commercially here in the United States or anywhere around the world, but I'm going to give you guys a glimpse of the early data just to excite you about what's about to come. This is this video. I wonder if we can start the video that shows how the injection actually works. There you go. So I'm going to, oh, it didn't work. So Let's see, and go back to it. If the video doesn't work, it's okay. It just shows how we actually inject the disc. Can we go back one slide, please, and see if we can get the video to work? So placing Regeltech or the hydrophil product inside the nucleus of the disc is just as easy as doing a discogram. We've all been trained in placing the needles right inside the nucleus of the disc to inject various types of products in there. This is a 17 gauge needle. The hydrophil product needs to be heated to about 65 degrees to be liquefied. The needle is placed inside the nucleus, and the hydrophil product is injected using a pressure syringe around the degenerated nucleus and within the disc itself. This animation shows how hydrophil fills the nucleus and the desiccated area quite well, but what it doesn't show is that this product can actually fill the fissures and potential annular tears inside the disc itself. The injection doesn't take more than a few minutes to do, and just about anybody who does interventional pain management has the appropriate skill set to perform this procedure very easily for their patient population. Next slide. So hydrogels have been tested for years for the treatment of lumbar degenerative disc disease with different techniques and materials, but earlier approaches really involved a total denucleation. The early results also showed us some expulsion of the product outside of the nucleus of the disc itself in the epidural space. But for the ones that were successful, we could validate the fact that the biomechanics and the disc volume can be restored with the right product. The materials were stiffer and thicker earlier on, but showed biocompatibility, but there was obviously a need for something that could be liquefied to be placed inside the nucleus itself. Next slide, please. So the hydrophil product is a very exciting mix of polymers of PBPP, GMPVA, polyvinyl alcohol, polyvinyl propylene, and polyethylene glycol. It's injected at 65 degrees through a 17 gauge needle right inside the nucleus. And it solves the expulsion problem altogether, mainly because of the fact that it has cohesive properties that actually adheres to the nucleus, to the annulus, and actually the end plates themselves. As the product cools within the body, it gels and it becomes more of a consistency of soft rubber inside the nucleus itself. There's also sterile barium within the product that gives it radiopacity. So as the product is being injected, the doctor can potentially monitor the spread. If a discogram has been done in the past, then clearly the spread of the product within the nucleus itself can be quite predictable, like the discogram. Next slide, please. So as I said, it's a very simple procedure. A 17 gauge needle will suffice within the disc. The treated disc usually does not show any further degeneration. And with the hydrophil product in place, the disc can maintain its height. The hydrophil product itself maintains its hydration, and the disc can maintain its mechanical properties as well. In the animal and the cadaver studies, the gel does adhere to the nucleus, to the annular fissures and the small annular tears, and also to the end plates themselves. The early feasibility study is ongoing, and I'm about to share some of that data with all of you. Next slide. So the early feasibility study is actually being conducted in Colombia, in Barranquilla, Colombia, to be exact. Dr. Alfonso Paz. Spath is the interventional radiologist in Colombia that's leading the study for us. He's already treated about 20 subjects in the study, but the study has been increased to 50 subjects. We are currently in the process of getting permission to take the team back into Colombia to treat 30 more patients. The procedure's primary endpoint, the primary safety endpoint, is no severe adverse events. And obviously, we want to see the primary performance endpoint of seeing the hydrophil in place that's been successfully delivered as a gel inside the nucleus itself. Next slide, please. You can see how the hydrophil product is actually being inserted right inside the nucleus. 20 patients have been treated so far. 11 patients had single-level implants, and 9 patients had 2-level implants. So in effect, 29 discs have been treated so far with this product. Next slide. About 70% of the subjects were female, 30% were male. And as you can see, the average age is right in the early 50s, which is basically the sweet spot for moderate to severe disc degeneration with the axial low back pain present. We think this is going to be the right demographic for the type of patients we would potentially treat in the future with a product like this, should the product ever come to market. Next slide. Looking at the levels treated, the two major levels were L5S1 and L4-5. Obviously, those are the two levels that suffer the most degeneration based on the biomechanics of the spine. The peak modified Fairman grades were grade 4 and 5, but as you can see, we treated the modified Fairman grades all the way up to Fairman 8 in this study as well. Next slide. The baseline pain score for these patients' axial low back pain was an average of 7.1. At the 6-month mark, for the 19 patients who reached the 6-month mark, had a baseline score of 2.1 for their axial low back pain. The limb pain was reduced from a baseline of 4.8 down to a very impressive 1.5. All a very step in the right direction with really excellent results so far. Next slide. Aside from that, we always look at improvement in the patient's function. What we saw was an 85% improvement in the patient's oscillating disability index based on the data they reported to us from their baseline. And again, for these 19 patients, a huge step in the right direction. We think that a significant number of these patients suffer from degenerative disc disease to some point. They haven't decompensated to the point that the failed back surgery syndrome patients do. So we think that they can bounce back a lot faster if they're treated with the appropriate treatment medium. Next slide. So this is the EFS study is ongoing. In Barranquilla, Dr. Alfonso is continuing to inject these patients for us as soon as we get permission from the Colombian government to take the team back in there. We think that we should be able to complete this study by the end of this quarter in 2021. After that, in mid-2022, a US pivotal study will start. The company is hoping to be able to take the PMA pathway forward. And by the way, the FDA granted the company a breakthrough device designation for Hydrofil in December of 2020 that allows them to be able to fast track the product through approval if the data is promising. Next slide. So in summary, the hydrogel injection is really promising and it can provide immediate profound improvement in patients' pain function. It's proven to be very safe so far. It's best in discs with moderate to severe disc degeneration, and it can act as a surrogate for lost disc tissue and at the same time maintain the mobility of the disc. The patient candidates can be quite prevalent in all of our practices at this point, and it's a very simple procedure to perform. I hope to be able to bring you much more robust data in the near future with this. Thank you for all.
Kaz, that was an elegant and wonderful presentation as usual for you. So we appreciate that. I love the Colombian folks. I've gone down to speak at their annual meeting a few times, and they just do some great medicine down there. And so I think that would be a great country to do the initial feasibility work. My first question for you, though, is going to be, we hear all these different disc techniques. You and I have been involved in a few studies together with stem cells, and there's been other autologous cells, and then there's this type of product, and there's other things. Can you just give us very briefly the different categories of intradiscal therapies that are currently either being investigated like this one or already available to us?
Absolutely. I think that that's an excellent question. So I think in general, you can categorize the products that we're testing within lumbar degenerative disc disease into 3 categories. There's the synthetic products like Hydrofil. There's the stem cell products like the Mesoblast product, the Vivex product that have recently been shown to be very effective for the treatment of lumbar degenerative disc disease. And last but not least is the non-stem cell but natural products such as nucleus pulposus or hyaluronic acid. Those things are being studied as we speak, and hopefully we will have a clear winner in the future. But there's no question that we are looking at very effective ways to be able to fill this treatment gap.
Hey, Kaz, I have a question. Firstly, great presentation. As always, this preliminary work is revolutionary, groundbreaking. With all of the axial low back pain treatments that we have available, we have neuromodulation, we have restorative therapies, we have a lot of intradiscal things that Dr. Deer described. How would you help the physician that's seeing someone in their practice that has low back pain? How would you recommend management or creation of an algorithm to help them decide what to do first? What's the most prudent next step when someone comes in with axial low back pain?
Yeah, thanks, Jason. Yeah, so as all of you know, some of the best evidence is for conservative care for low back pain, such as exercise and physical therapy and functional rehabilitation. I published a paper some time ago on the evidence-based approach to failed back surgery syndrome, and through that paper, we found out that there's a lot of very good level 1 data for exercise and physical therapy. I continue to feel that we need to be able to treat our patients with the most conservative measures first, and if they fail, this could potentially fill a very big gap before these patients graduate to their surgical option. If we can capture these patients early on within the algorithm, if they fail conservative management and treat them with products like this, hopefully we can avoid major surgical intervention for them, at least early on.
Great.
And Kaz, I have one more kind of specific question for you. Great job as always. You know, one issue I have with a lot of these intradiscal studies is I feel like applicability to a real world practice is rather difficult. I've seen some of the inclusion exclusion criteria, and some of these patients have, you know, Furman grades that are kind of in the area where a lot of my patients are asymptomatic. I see patients usually with kind of advanced degenerative changes. I noticed in this study, about a quarter of the patient had advanced Furman grade degeneration, 6, 7, and 8. Was there, and maybe I missed it, was there any change in the degree of response in those patients with advanced degenerative changes in this feasibility study?
Yeah, it's an excellent question. Because of the properties of this product and the behavior of this product within the disc itself, we think that we can potentially treat more advanced modified Furman grade discs with hydrogel. However, at this point, we haven't teased out the data enough for us to know what the outcomes are, for example, for a group with modified Furman 8 versus modified Furman 5. But the way the product is behaving within the disc itself is quite promising, and we should be able to treat more advanced disease processes with hydrogel than, say, with stem cells or other natural products out there.
Okay, Kaz, well, thank you so much for a great question and answer and a great presentation. Now we'll let you step off to your other event, and we'll go to David Syed. David.
Thank you so much. Have a good evening.
Well, thank you very much. I'm pleased to be able to present the next research that was presented at Aspen this year. This I'll be discussing our Salvage study and our real-world outcomes with using a novel posterior-based minimally invasive sacroiliac fusion device. My personal disclosure is that I am a medical advisor and consultant for Pain Tech. Next slide. So again, when you talk about, you know, the Lynx device, what it is kind of a patented posterior cortical allograft that has a patented graft window, and we think that large graft window is really critical in some of the long-term real-world outcomes that will present. You know, it serves as a bridge for fusion to occur. There's also some very unique characteristics of the instrumentation, as well as a drill-less methodology that we feel also leads to the excellent safety profile of this technique and technology. Next slide. So this is our multi-center real-world study. So again, what we have here is that single point fusion using a posterior approach allows for the least amount of tissue dysfunction or disruption. When you look at our cohort here, out of the 50 patients, about 26 of the patients did not have prior lumbar surgery. 24 of the patients had lower lumbar surgery, with 17 of those having lumbar instrumentated fusion. Again, what we noticed in this 50 patient cohort, this was done from cases at our own center at the University of Kansas, as well as a couple of private practices across the country, Dr. Kevin Balters and Dr. Stephen Piles. We noticed that this was a very safe procedure. There were no major complications or adverse events. Also, no further interventions were needed in the sacroiliac joint after the Lynx implant was done. Next slide. So here are real-world study results. You can see we've kind of broken this up in a subset analysis where kind of the overall pain relief, and then also the pain relief in patients that were either lumbar surgical naive or had prior lumbar surgery. We all know that the incidence of sacroiliac joint dysfunction in patients with prior lumbar surgery is quite high, anywhere from 30 to 50% on the published literature. But again, you can see all of these patients had pretty significant pain. Again, chronic sacroiliac disease is typically can be very painful, and that's kind of bore out in this real world study where you see average VAS scores of greater than 7, or around about 7.5. And you can see at their last follow-up, we were able to decrease the pain by around 60%. Again, you can see a higher trend in the patients with prior lumbar surgery, but overall, the patients with no surgery also did quite well with an average pain reduction of about 60%. The overall pain relief in the entire cohort was, again, around 64 to 65%. Next slide. We'll switch now over to the Lynx Salvage study. There was one last point on that, the average follow-up, and that was around 600 days. So again, pretty robust long-term outcomes in that, which really hasn't been published or presented before for posterior SI fusion. The next study I'm going to present is the Lynx Salvage study. So again, early on, many of us that have incorporated minimally invasive posterior SI fusion have noted that it can be a very useful adjunct in patients with previous implanted pain devices, specifically spinal cord stimulation, specifically patients that have had spinal cord stimulators implanted for things like failed back surgery syndrome. What I've noticed personally is that, over time, as patients develop more mechanical pain from the sacroiliac joint, the spinal cord stimulator is started to be adjusted to be used more for that mechanical pain rather than the neuropathic pain that it was originally implanted for. So what we see is these patients start to quote unquote fail their therapy. They say their spinal cord stimulator isn't working. Same can be said for things such as intraspinous spacers, intrathecal pumps, and some of the other minimally invasive lumbar decompressive surgery. So we looked at this full cohort. So across many centers, this was actually led by Dr. Tim Deere. We looked at about 111 patients that were kind of failing their originally implanted therapies and saw could we kind of salvage these patients or make these patients responders by actually stabilizing their SI joint with the Lynx implant. So essentially what we did, and in the majority of these patients were SCS patients, we'd have the patients turn off their SCS for about 24 hours and do a diagnostic sacroiliac joint injection. If the patient would receive greater than 50 to 75% in that range of pain relief in their typical pain, the diagnosis was pretty clear cut that most of their pain was attributed to the sacroiliac joint, and we perform minimally invasive posterior SI fusion with the Lynx device. So here's kind of the baseline demographics of this, and that's kind of the methods of this. Again, this was a retrospective review, and we can go to the next slide to look at the results. So again, the mean pain reduction was quite remarkable in this. So a mean pain reduction of around 67%. So again, these patients had pretty significant pain even despite their implanted therapies such as spinal cord stimulation, intrathecal therapy. You can see that, in patients where you're trying to treat mechanical pain such as sacroiliitis with a spinal cord stimulator that's intended more for neuropathic pain, the efficacy can wane pretty significantly. So when we were able to stabilize that, we could see a significant reduction in pain. So again, around 67%. 52% of these patients were what I consider really profound responders that had 80% greater pain relief. And again, we also were able to show that this was a very safe adjuvant therapy to do. So no serious adverse events were recorded in this. And again, you can look at the different cohorts of patients. Almost everyone did a little bit better. Even you could say 90% of the patients did at least better than 30%. But again, a very significant portion of patients did better than 50% with that average pain relief being around 70%. Next slide.
So
I think
Delvin,
that's it.
Great job. I think your work has been really helpful. I'm looking forward to seeing the biomechanical studies that I know we'll be also presenting soon. But my question for you really is, I would just say that I think the posterior technique is certainly a less invasive, less risky technique than some other methods. And what you're showing there is some great real world data. My question really is, in the Salvage study, which obviously we were both involved in, I think it's important to note, and I want your opinion, were people really failing their other therapy, or is it more comorbidity management? What's your thoughts?
Yeah, I think most likely, I think it's a great question. I don't think that they are failing their therapy. I think what happens is these patients develop another comorbid condition. but the optics of it, and when they come back to our clinic, is that the patients aren't doing well. So I think when we look at some of these adjuvant therapies, and I know you led a really, similar study with using interspinous spacers for kind of clotting symptoms as well. So I think, now that we have multiple tools in our toolbox, we need to address these, these pathologies in very different ways. So again, I think your question's great. I think their therapy really probably didn't fail, but it's just a lack of treating it. Trying to treat everything with the spinal cord stimulator really is, I think, also leads to kind of lack of perceived efficacy of spinal cord stimulation. So I think these adjuvant therapies are critical, and being able to do things that are very safe and minimally invasive is also key, because a lot of these patients don't want to have another major operation. So I think that's what's also unique about things like the posterior SI fusion is, hey, you can just come in, pop in, outpatient procedure, and you can get back to your day. Trying to get these patients to jump into another big major operation is also challenging. So I think that's also unique with this.
Yeah, I think this is really valuable. So appreciating that the spine is dynamic and that there are comorbid things that happen through the lifetime of someone that has stimulation therapy. The appropriate diagnosis is important. Clearly, if we're going to intervene. The question I have is, in my experience with sacral joint fusion using a posterior approach, the time point on when we assess percentage of pain relief is critical. So in looking at the study cohort that you're presenting, what was the average time frame that you assessed whether someone was better or not following the procedure? Was it 3 months? Was it 6 months? Was it 12 months? Was it a year? How did you define, or when did you decide when to survey those patients on how well they were doing?
Yeah, that's a really great question. Obviously, with what we know about fusion, sometimes, there may not be immediate relief. We really do see pretty quick relief with this therapy, though. I think, the mechanism of action with a posterior approach is really twofold. I think you get immediate stabilization. You essentially distract that joint, so that joint's not grinding on it. So, when we looked at these patients, even immediately, follow-up, as close to 1 to 2 weeks, we saw that trend down in the pain relief around that 60 to 65%. Fusion, as we see, takes a little bit more time, somewhere in that 3 months to 6 month window, depending on, some other patient factors. So I think, when you look at that, you see that sustained response greater out to 6 months. So I think our average follow-up in this cohort was around 5 to 6 months. So I think hopefully we'll have some more long-term data on this, but I think, you kind of see that relief fairly quickly, which is nice for these patients in chronic pain. And I think that's something you probably don't see with some of these other approaches to sacroiliac fusion, because you don't really get that distraction right away. Compression, you may not see that, which is something you probably achieve with a lateral fusion.
So I just want to make one comment, Dawood, before we go on to Chris Gilmore, and that is, one of our attendees asked a question about what were the findings when someone was filling a stimulator and they were salvaged with posterior SI fusion or fixation, and we used a classic SI joint diagnosis criteria, 3 of 5 physical findings in the history. So, I would recommend that you always use the same criteria that we would use for any other SI procedure to diagnose SI joint disease, including the history and the physical findings. And if you don't have those handy, we'll be publishing a paper with Patrick Buchanan leading a study on that very soon. So with that, I'll give it back to you to introduce Dr. Gilmore.
Great. So our next presenter today will be Dr. Chris Gilmore. He's a powerhouse researcher and clinician out of in the Carolinas, with a lot of notable colleagues as well. He's been essentially kind of a pioneer in PNS and peripheral nerve stimulation. He's going to discuss which was one of kind of the most talked about studies that was published at our annual meeting, a prospective multi-center study on percutaneous medial branch nerve stimulation for the treatment of chronic axial low back pain. Dr. Gilmore, the floor is yours.
Hey, thanks, Dawood. I hate to follow you and Cass. You guys are so incredibly eloquent, but thank you guys for having me. I've been doing research on temporary percutaneous peripheral nerve stim for quite some time now. I think this is my 12th year of using this particular device that we utilized in this study in clinical research, and with this most recent publication that came out a couple of months ago, I really would like to credit my co-authors that are all listed there. A lot of the usual suspects when it comes to peripheral nerve stim and publications in the space. So kudos to Dr. Syed, Dr. Lee, and all the rest of the gang there. And you know, if your practice is anything like mine, and I'm sure it is, chronic low back pain, axial low back pain is the 800-pound gorilla of your practice. Those patients are everywhere. So I think that, you know, we may be on to something with these therapies that we're speaking about tonight, and I'm happy to share the results of our most recent publication. Next slide, please. All right. I do sing for my supper occasionally, and like I said, I've been doing research with this device for the last 10 or 11 years. So there you have it. Intro, again, very, very common population, utilizes more, there's more money spent or on treatment of axial low back pain than just about anything else in the medical field. And with this particular device that we're utilizing here, it's minimally invasive. If you can place a needle there, you can place this lead. It's really no more invasive than a particular than any other nerve block. Minimally invasive, 60 days, temporary percutaneous peripheral nerve stimulation. It's non-opiate, it's non-ablative, it's non-surgical. And what we're really trying to do here is establish where this fits in the treatment continuum. And that was kind of the goal of this study, to assess the responses, but really kind of take a step back once we've gotten the results of the full 12-month follow-up of these 74 patients. Okay, where do we place this in our armamentarium? So next slide, please. All right, so the patients we chose, chronic axial low back pain for more than 3 months, stable medication regimen, no radiofrequency ablation or prior surgery within the last 6 months, though we did kind of include a cohort of post-surgical patients that, you know, if anyone wants to talk with me offline about that, I'd be more than happy to. No anesthetic injections within 3 months of stimulator implant, and the BDIs were less than or equal to 20. So once we placed the leads, participants received stimulation of the lumbar medial branches, activating the multifidus for 6 to 12 hours a day, up to 2 months. And with the minimally invasive and non-intrusive design of the device, patients were allowed to and able to really continue their normal activities, which is a really, really important aspect of this minimally very small, tiny device. And at the end of the 2-month treatment period, the leads were removed with gentle traction. So it's easy in, easy out. And once patients completed the treatment, they were followed up to 12 months at post-treatment. So for a total of 14-month observation period. Next slide, please. So the device itself, it's a really, really small, size of a human hair, a microcoiled lead. It is 0.27 millimeters in diameter. And the way I describe it to participants and patients is that it looks like an old telephone cord. It's a really, really tight coil. It's brilliantly designed, intended to mitigate against migration and infection. The tissues actually grow into the coil over the course of the 2-month period. Actually, that happens fairly quickly. You know, 15 years ago, if you told me I was going to place a lead into a patient, leave it for 2 months, you know, it brings to mind the joke, you know, what do you call an anesthesiologist in a suit? The defendant. I would expect infections all over the place, but with the way this lead's designed, it really mitigates against that. And there's actually published data that demonstrates it's about 23 times less likely to get infected compared to just a cylindrical lead or catheter. But leads were implanted under ultrasound or fluoroscopy at the level of the medial branch that's in the middle of the region of pain. Anybody, I'm kind of at an inflection point. There are not very many people older than me who are really used to using ultrasound, but everybody younger than me is way better at using ultrasound. So, you know, there you have it. So, but this device is designed to be implanted either way. I tend to use ultrasound, so I can kind of really identify the belly of the multifidus, place it there. You don't really need to be hugging the nerve. Actually, there's some data that demonstrates that you can place this remotely away from your target nerve and still get appropriate stimulation. But with ultrasound, you do get to identify isolated selective activation of the multifidus, which is innervated by that dorsal ramus of the medial branch. Next slide. Oh, I just noticed one other thing. Continuing with the one-off baseball card thing, I've got one L in my name, and I'm speaking as Christopher Gilmore. So this is great. Michelle, please send me these. So results on the left side of this slide, you see our target audience, average age of 56. Again, these are your people who are up, around, working, contributing members of the population. They're active and contributing members of society, I should say. Body mass index was just under 30. So here in North Carolina, below the Mason-Dixon, that would be considered really skinny. Low back duration, average, and this is key here. Average duration of low back pain in this population was 16 years. And just over half of the patients were female. The baseline opioid usage was not quite, it's in that low to moderate range of 32 morphine milligram equivalents per day. And you can see the previously failed low back pain treatments of this participant population. And just to kind of cut to the chase, the right side of the slide, for those who aren't inclined to kind of see visual representation. Anyway, clinically and statistically significant reductions in pain, disability, and pain interference were reported by a majority of participants, excuse me. And those were sustained throughout that follow-up period in the majority of patients. So not just at end of treatment, at the end of 2 months of treatment, but out to 14 months from the start of treatment, these reductions in pain, disability, and interference were maintained in this patient population that had an average duration of low back pain of 16 years. So 60 days of treatment after 16 years of pain in the majority of patients produced clinically and statistically significant reductions in all of these measures. Majority of patients reported statistically significant quality of life improvements, and just shy of 60% reported they were much improved. So it really is a very impactful therapy in a huge patient population with a long duration of symptomatology, and so I'm really happy that we've gotten to this point with peripheral nerve stimulation, where we have a device that's specific for use in the periphery. We're no longer having to kind of adapt spinal cord stimulator equipment for use in the periphery. We've got something that's designed to move, to stretch under the skin, to mitigate against migration and fracture and infection. So I think we're really on to something. And what's really nice about this study is that while I've been involved in previous studies at my center, the Center for Clinical Research here in Winston-Salem, those results with this publication have proven to be replicable. So this is a multi-center study. It's a number of different implanters, a number of different methods, a number of different experiences with the device or duration of experience with the device. But the results from the early studies are repeatable, and I think that's the real impact of this device or the study. And I think that's what long-term is going to get the attention of things like the payers and things. But I digress. Bottom left-hand corner, you can see the etiology of the pain. We took all comers, lumbar spondylosis, degenerative disc disease, and quite a large segment of the participant population fell into the non-specific low back pain category. Next slide, please. So the and I've said this several other times, the party trick about this device is not that it works while it's implanted, or the traditional thinking with neuromodulation is that the device needs to be on for it to be functioning. And what we see during the treatment period, while the device is on, that 6 to 12 hours per day, patients get a very abrupt drop in their pain scores. So the average pain intensity over that 2-month treatment period, as evidenced there on the right side of the screen, dropped very abruptly. On average, and the primary endpoint was clinically significant reduction, or 30% reduction in their pain scores. The average reduction in that responder population was 58%. But again, the real key to this device is that it doesn't only work while it's in or while it's on. Once the leads are removed at that 2-month endpoint, and we follow these patients out for another year, these reductions are maintained. What you'll see in this slide and the next two is that 73 is the number of the day. 73 is now my favorite number. So 73% of patients were responders with that primary endpoint in average pain reduction after 2 months. Next slide. And you'll see that 73% of participants experienced clinically meaningful reductions in their pain-related disabilities. So their ODI was reduced by significantly in 73% of the participant population. And that average reduction was 21% among those responders. And similar to the average pain intensity, that reduction was maintained for a year after the leads were removed. So it doesn't just work while it's in. It's kind of retraining the body. It's creating a new experience for the body. And once the leads are removed, the body or the mind, brain, the central nervous system, the musculature around it, it's all kind of gotten used. Hey, I kind of like having less pain. I think I'm going to maintain this for another year, and that's or at least another year. That's what we saw with this study. Next slide, please. And continuing the theme, 73% of the participants experienced clinically meaningful reductions in their pain interference. So the BPI-9 was reduced, the BPI-5 and the LDI were all reduced in 73% of the population to a clinically significant level. And that average reduction in this pain interference was approximately 67% among that responder population. And again, it's the same curve. We're just using different axes. It's maintained out to 14 months from start of treatment. You see a very abrupt drop in pain scores, pain interference, and disability, and that drop is maintained for at least a year. And in the next study that we're looking at, we're going to be following patients out, or participants out to two years. Next slide, please. And I know I said earlier the patient population that we were looking at, it was a low to moderate opiate use population, but we did have a significant reduction in opioids with 21% of the participant population actually completely eliminating their opiate use. And that's out to 14 months. Next slide. So, clinically meaningful and statistically significant reductions in pain, disability, and pain interference reported by a majority of the patients. And with this, the simple nature of the device, the minimally invasive kind of nature of the device, I think we may be able to move neuromodulation earlier in the treatment continuum, and particularly for those practitioners who are not very comfortable with permanently implanted devices. So thank you very much for my time, guys.
Great job, Dr. Gilmore. I think these results are really impressive, especially the sustained response we're seeing in the cohort that you present on. One of my questions is, it seems like the application is fairly broad. When I looked at, spondylosis, degenerative disc disease, and non-specific low back pain, how are you kind of using this in a real world practice to kind of select this for this therapy versus, say for instance, just a radiofrequency ablation, which is kind of that same target?
So I know we all have our preference on how we treat these axial back pain patients. And what I'm attempting to do in my clinical practice is kind of mirroring what we're doing with the study we're working on the clinical research side of things. With the current study, everyone enrolled gets medial branch blocks from the start, and then they're being separated into peripheral nerve stem versus conventional medical management, be it going down the radiofrequency ablation pathway or non-invasive therapies, or et cetera, et cetera. So I'm actually kind of using that same approach with my clinical population in practice. I'm these axial back pain patients who present with what appears to be a facetogenic etiology. They've got spondylosis on exam, or if they don't, but I have an inkling that they could potentially be medial branch mediated pain patients, I'll block them. And that the response to blocks actually kind of helps me a fair bit with choosing whether or not I go down the peripheral nerve stem pathway versus the normal peripheral radiofrequency ablation pathway. One of the other things is that I've really started to incorporate assessment of segmental instability into my clinical practice when I examine a patient. So while this is peripheral nerve stimulation, it's not intended to be restorative or functional restorative stimulation. We are activating muscles that tend to be neglected by axial back pain patients. And in that population, you oftentimes will see weakness in the multifidus. So there are a few different tests that we can do with physical exams to assess whether or not patients have segmental instability. And in those patients, I will go straight toward peripheral nerve stimulation.
Chris, I consider you the world leader in this area of medicine, PNS for the low back. So thanks for that presentation. I have in the interest of time, I have a very quick question. I think it's going to be important for our listeners to understand this. We always use ultrasound for median nerve or suprascapular nerve, and that's our preferred method of placement. How about for this procedure? Is it fluoroscopy, ultrasound, or both?
I think it really is what you're most comfortable with. Everyone here has done a medial branch nerve block. Everyone here has done hundreds of medial branch nerve blocks. If that's what you're comfortable with, whatever way you tend to do it, I think that's the way you go with. It's important to be consistent, but if you want to kind of branch out, it is very easy either way. A lot of people will use fluoroscopy to place the leads, but ultrasound to confirm that you're getting isolated contraction of the multifidus. I think that's and it's really quick. It takes no longer to do that than using fluoro alone or ultrasound alone. And I think that is probably the best of both worlds.
Yeah, that's exactly what fluoroscopy then ultrasound with the multifidus. So I think you and I are on the same page. Thank you for that, Jason.
Yeah, I was going to ask just a really simple execution question. So when we approach medial branches for a lumbar spondylosis, we usually treat more than one level at a time. And part of the methodology section, you had talked about going after the middle portion of the pain area. I did not see in the data presentation where most commonly you placed the leads. And then how many leads did you place? Was there one on one side, or was it one bilaterally, or just walk us through really quickly how you actually executed placing the lead and where you did it?
Great question, and thanks for allowing me to clarify. So when I first started doing this, I'd map out the region of the patient's pain. And I would use my ultrasound probe, and I'd scan and find the spinous process in the middle that bisected that region. When we examined most of the patients, when we examined the patients in our studies, the most common level was at L4-5. I would have thought it would have been at L3, but it really was at L4-5. So that was the most common. And patients received one lead on each side. When you use your ultrasound probe to scan up and down the lumbar spine as you're stimulating, you'll see that you actually stimulate multiple levels. So there's replication in stimulation. So you'll see multiple levels of the multifidus activated with only one lead. So you're actually engaging several levels of fibers.
That's tremendous work. Thank you.
Thank you.
Thanks, Chris. We appreciate you.
Thanks.
So on to the final presentation. Can we tee up the slide for Dr. Deer? Jason, you want to do the intro?
Absolutely. It's my pleasure to introduce my good friend, colleague, and mentor, Dr. Deer. He's the founder of Aspen and the chairman. And he's going to walk us through a really, I think, novel study when we look at the need for randomized controlled trials in our space. And when we look at the evolving space of minimally invasive spine work to treat neurogenic claudication, Dr. Deer's been I think a world leader in that effort. And so I'll turn it over to him to walk us through this mild motion study, 1-year results. Dr. Deer?
I'll be efficient, but I want to make sure I cover this quite well. This is a level 1 study. Disclosure-wise, I've been a consultant for Vertos, helping them design this study, along with Dr. Nagy McHale, my dear friend at Cleveland Clinic, who served as a safety monitor for this study. And we have a multi-center study, so I'm presenting on behalf of all the investigators. And I must say, our clinical investigators could really not be done without the on-site research directors. So I want to give a shout out to them as they watch this video later on. They did a phenomenal job. This is 1-year data. We'll be following these patients out further, but I want to give you this presentation tonight. Next slide, please. So many of you are familiar with the mild procedure. We go in and we decompress the ligament. We have a ligamentum flavum hypertrophy. We look for the ligament. We see it causing part of the compression at 2.5 millimeters of thickness or more, causing spinal compression. So the purpose of the study was to look at the objective functional improvement of those being treated with this and compare it in a real-world setting in a prospective, multi-center, randomized controlled fashion. We had mild versus conventional medical management. And on the right-hand side of the slide, you see what the CMN included, and there was things that weren't included in CMN, which is a license of adhesions, neurostimulation, a spacer, or surgery. And if you got one of those therapies, then you were really a failure at that point. So they were disallowed procedures. With the crossover was at 1 year, and so you're allowed to continue as a subject after 1 year. And then we did data analysis at 6 months, which we recently published. You can find that in the Journal of Pain Research. 1 year, 2 years, 3 years, and we're going to follow these patients all the way out to 5 years. So we'll have 5-year data on this procedure, and I think that'll be one of the 2 studies in our field where we actually get 5-year outcome data. And I encourage other investigators to do the same going forward. But now I'm giving you the 1-year data over the next 5 or 6 slides. Next slide, please. So we had 155 patients enrolled. Now, again, we screened more than that, but they had to meet the study exclusion criteria. 77 got mild plus medical management. 78 went to medical management alone. Next slide, please. You may recall I showed you what medical management was, but we want to make sure we have equal groups. So we actually had demographics and baseline function, and we found that they were the same in both groups. And you can see there the breakdown. So I think that's very important, very, very similar in their function and their pain scores and their body habitus, their age and their gender. Next slide, please. And so the other thing I think many of you might be surprised by, but you need to understand this, and we saw the signal in other studies of this procedure earlier, but we really wanted to look at a heterogeneous group of spinal stenosis patients. So they all had ligamentum flavum hypertrophy, 2.5 millimeters or more, as we measure that. And I know in our practice, for example, We measured that ligament carefully, and what we found is that you see on these slides, when they most of them presented with multiple types of stenosis. So they didn't come with just only ligament hypertrophy. You had central, lateral, and foraminal stenosis in many cases in the same patient. So why would that help to decompress the ligament? Well, it goes back to physics, to the Bernoulli equation. When you decompress a ligament, you lower the pressure in the canal. So we see that you don't have to have only central stenosis. Many of these patients had comorbidities, so they had more than just spinal stenosis. They had facet joint hypertrophy. They may have had disc disease. They may have had some spondylolisthesis. So all those factors were looked at, and almost 72% of patients had some comorbidity. 91% of patients presented with 5 or more spinal comorbidities if you looked at all the findings on the MRI. So pretty really disease group of folks that we're trying to treat here with this procedure. Next slide, please. And I think most of you in chronic pain practices will find that is the real world setting. The majority of these were performed in hospital outpatients. Some were performed in ASC, as you can see the numbers there. The most common anesthetic was MAC. The most common level treated was L4-5, followed by L3-4. And those are actually the most common places we see clinical lumbar spinal stenosis in normal practice. 90% of people had bilateral treatment. Even when people have unilateral symptoms, many people feel that decompression should be bilateral to open the space more thoroughly. 59.7% had one level only, 31% 2 levels, and then 8% 3 levels. So the majority of people had 1 or 2 levels. I think that's what most of you will see in the real world of clinical practice. Next slide, please. So we also looked a lot at how to avoid bias in the study. So there was an independent clinical events adjudicator, did not treat. The PI did not treat. There was a medical monitor who did not treat. There was written instructions and scripts followed by the really all the staff at each of the centers. So there was no Hawthorne effect of someone trying to talk someone into doing better. So we really used all the modern criteria for study investigation to try to really eliminate and reduce bias. And we also used objective real world outcome measures that have been validated, like a walking tolerance test, which I'll show you the data of, which is pretty amazing. Subsequent disallowed procedures, which make you a failure by definition, and then instance of device or procedure related AEs to look at safety. So that's really some of the major design, I think, advantages of this study compared to many other studies done in the space, sponsored by a company looking at investigation for level 1 data. Next slide, please. So outcome measures, you see here, subjective outcome measures on the left, ODI change for patients with a disallowed procedure, and imputation of 0 ODI change for patients receiving a disallowed procedure. So they went to 0. On the right, you see the walking tolerance test, which I mentioned a moment ago. Patients walk up to 15 minutes at their preferred speed, and at 15 minutes, we see their symptoms. That's the walking tolerance test. Subsequent procedures and safety. And then we go back to independent assessment of those criteria. Next slide, please. So what do we find? I mean, I think this is going to be really breakthrough data for us. Here's the mean ODI, and you see there's a markedly statistical significant data difference at 1 year with superiority of mild and CMN compared to CMN alone. And if you think about someone who has spinal stenosis, this could be the difference between life and death as far as their mobility, because we know that sitting is attributed to more disease and earlier death than mobility. So I think this ODI improvement was quite significant, is very, very important. Next slide, please. What about the ability to walk? You see here a 258% improvement in the mild group and a 64% improvement in the CMM group. That's markedly statistically significant with greater than 200% more improvement really in the mild group. Now, what's really interesting is the CMM group did improve. So other things that were offered the patient did make some difference. And I think it goes to show you that, we certainly can have improvement just by paying attention to a patient and really give them some form of care. But I think this walking tolerance test is really great level 1 data for a procedure showing the difference and the only variable being the mild procedure in that group of patients. Next slide, please. So we improved the ODI, we improved the walking tolerance test, and then we looked at disallowed procedures. And you see a marked improvement in the number of disallowed procedures. It was 4.5 times higher in those who went to CMM, so compared to the mild group. So Those people didn't do well, and they had to go out and have another procedure to remain functional in any fashion. So 18 out of that group had a disallowed procedure, only 4 in the mild group. So that's a major statistical difference to 0.002. So they walked better in the mild group. They had better ODI overall. They had less disallowed procedures. Let's go to the next slide. And safety, and so certainly I published a paper about a decade ago with a young man who just got out of fellowship named Leo Capro. You may know Dr. Capro now. He's certainly a world leader in many areas. But we looked at the early data on mild. We found it was very safe, very similar to an epidural steroid injection. And this study looking at CMN alone versus mild plus CMN, the total AEs were almost exactly the same. The p-value, as you see, is non-significant, and there were no related serious adverse events in either group. So there's some unrelated ones where people had other disease processes overall. So 1 year, the safety of the mild procedure was equal to having no procedure at all or other alternative procedures within that list of accepted procedures. So that, I think that really is important as we talk about why we do minimally invasive things. Because in the algorithm, it's less dangerous than the larger open surgical procedures. Next slide, please. So let's conclude. This is a level 1 evidence study. There's not many of them in our field. It's rare we have a level 1 study in most of our therapies. We have 1 year data. The 6-month data show great outcomes. At 1 year, they were maintained and durable. I think we have to show durability. And as a first-line therapy, if we perform this procedure and someone does well, we have a good outcome, then that's wonderful. If they don't do as well as we hoped over time, we haven't burned any bridges. They can have other methods like interspinal spacers, stabilization devices, open surgical techniques. So I think that's the other thing that we'll look at over this 5-year period as we follow this group of patients. With that, I'll give it back to Jason and Dawood for any questions.
Yeah, Tim, I mean, wonderful presentation. I think, as I said before, the need to have level 1 data in our space, helping drive the access to minimally invasive spine procedures for patients is critical. And you've done a tremendous job with this. I noticed that when we looked at outcomes associated with the study, a lot of the outcomes were driven around functionality. The ODI scores, the ability to walk. Was there any discussion or assessment regarding a pain relief profile in terms of pain intensity? That's the first question. Second question quickly is, when we look at the onset of pain relief associated with the mild procedure, was there any trends that you could identify in when patients could expect to feel benefit from the therapy, appreciating that it's enduring out to a year?
Oh, two great questions, Jason. So I think, overall, what we see here is a 2 to 4 week, sometimes time for really starting to see improvement. And I think that really goes back to getting over the initial procedure itself, which is really pretty minor, but you will have some soreness and some need to ice and rest for several days. So we're looking at a 2 to 4 week really period where we start to see that improvement. About 3 months, we start seeing that improvement be significant statistically. By 6 months, they actually get even better. And I think that goes back to functional strengthening of the limbs. When you've had that stenosis for so long, you lose strength. And I think it's important in real world practice, not in the study, but we go back to a strengthening PT program at 6 weeks. But in this study, that wasn't part of the protocol. The other question you asked about function versus pain, the pain scores were certainly much better in the group who got mild versus CMN. But as you noticed, this study was designed to focus on function. And I think that's how we should design future studies of minimally invasive spine, because if your pain is better and your function isn't, does it really matter that much in the end of really the patient's life and care? So this study was designed specifically to look at functional analysis. I think that's really what we should look at going forward. And I think we got to get away from the numeric pain score, the visual analog scale, get to things like PROMIS 29 that you've worked a lot on, Jason, get to things like ODI and all those other factors. So that's where we're going. This is one of the first level 1 studies in our space that really focused on those things. And I think that's really a great attribution to the steering committee of this, including Dr. McHale, to look at function.
Yeah, I really applaud you for your work. That's tremendous. Dawood?
Yeah, I mean, I think Tim, just to piggyback on what Jason said, again, tremendous work on this and kind of moving away from pain scores, especially for things that are dealing with a disease entity like lumbar spinal stenosis. You know, my patients often say, I know how to get rid of my pain. I just sit down, I don't do anything, and I have no pain. So, but I think one of the struggles may be in interpreting this is that, you know, we're so used to like, okay, we know like a responder is 50% reduction in pain. This improvement in the walking tolerance tends of 256%, you know, it is more just like a comment, you know, are we going to kind of maybe in the future figure out like what is kind of that target level? Is like 250%, you know, sounds really good, or should it be 500% or what? You know, I think you as an elite, you know, ultra marathoner, that might not be anything for you, but for, you know, our typical patient, is that really significant?
Well, no, I think it is, and I think, you know, meaningful clinical difference is going to be a new landmark for us. So, is there a meaningful clinical difference which can be validated? And again, that would be very, very important. And I think we have to change the culture. And I think one of the things Aspen's going to do going forward, and I think that's going to be very important for all of us, is we have to change the culture from is your VS 9 down to 6 or 8 to 5, or are you really better as a quality of life measure? And so I think we should really push hard for future studies to have pain as one of the factors, but a secondary objective, not the primary objective. The primary objective has to be quality of life, things like the EQ5, things like Promise 29, things like ODI. So quality of life and function have to be our future endpoint for all of our studies, in my opinion. And I think both of you would probably agree with that as we try to change the culture of our research space. And I applaud this study because it does that. And this is going to be the first level 1 study to do that in this space, I believe.
That's great. That's fantastic. So I think, you know, this concludes our session. There was really, you know, a lot of great research that we were able to kind of, you know, go back over and give it really kind of the appropriate emphasis tonight. So do we have a couple concluding slides? I'll let Jason talk a little bit about, you know, our upcoming Innovation Summit in January. I think it's going to be really exciting.
Yeah, really excited about this. So when we surveyed our membership and we surveyed our space, one of the things that was lacking is something where we could really have a really valuable, visible critique of the data that's available in our space, and to do so during a plenary session. And so the thought surrounding this advanced lab master's class and data reveal is really to give you the exposure to the best evidence that we have in our space to help drive prudent decision making, and then also to help critique and evaluate and refine the procedural aspects associated with the new things that we have in our space. So we're excited to offer this as I think a really landmark, hopefully annual strategy in January in Las Vegas, and we look forward to your participation. I think again, with the evolving space that we have, the time for Aspen to really be on the forefront and the tip of the spear in giving our membership an offering like this to give you the best data and the best way to drive these outcomes is really going to be critical. And so we look forward to your participation and your attendance at the event.
That's fantastic. Tim, closing thoughts?
No, I think Jason's right. I mean, we're going to have the research reveal of some top level research. We're going to have master's course for discussion, and we're going to have hands-on cadaver for both fellows, for those who've been out a few years who want to learn new techniques, and those who've been out 25 or 30 years. So it's going to be really a collaboration of multiple people sharing ideas, and Jason and Stephen Flowski, Eric running that overall course, and myself and Dawood there to lend advice and a hand. So I'm really excited about it. Thank you for all joining us tonight. Those watching later on video, certainly you can go to our website to register for that as well. So, Dawood, you get the final word of the night.
Yeah, I think, you know, one thing that we wanted to get out there early for all of our members, you know, both nationally, internationally, is to get our calendar out there. You know, we pretty much have our calendar set for 2022. I think we're really excited about the Innovation Summit at the Bellagio in Las Vegas on January 7th through the 9th. But we'll be following that up with our think tank, which is really, I think, one of the most unique meetings in our space. You know, it's really non-CME. It's with a lot of early stage companies and investigators and scientists talking about things that really aren't happening today, but that are probably going to happen in the next 5 years. So it's really a unique opportunity to really get a behind the scenes look at some of this stuff that you really can't talk about in, you know, traditional CME programs. So I think that's going to be great. It's going to be at the Virgin Hotel in Nashville, Tennessee in March. And then obviously our gold standard, our flagship meeting, the Aspen annual meeting, will be back at the Lowe's July 15th through the 17th in 2022. So thank you, everyone. I look forward to seeing you guys many times throughout the year and a lot of events like this as well. Good night.
Good night, everybody.
Thank you.